Thank you very much, Dr. Berna. Because my French is not very good, I'll have to assume you've given me a nice introduction there. Please put your hands up if I talk too quickly. I have a tendency to do that, so please calm me down by using your hands. So I wanted to give an overview of how to safely stop psychiatric drugs, and I'm outlining a lot of things that are in our textbook that we released recently called the Maudsley Deprescribing Guidelines, which is a companion to the probably more familiar prescribing guidelines. So I'm talking a little bit about what's happened in the UK, because I know that better than in France, but I'm sure that there are similar guidelines. So I'm going to talk about antidepressants in general, but a lot of what I'm saying will be relevant to the other drugs, benzodiazepines, gabapentinoids, and Z drugs. So the NICE guidelines, the government guidelines in England, said for many years that discontinuation symptoms from antidepressants are usually mild and self-limiting over about 1 week. This description was influenced by a lot of papers published in the 1990s and 2000s by drug companies, which focused on people who had used antidepressants for 8 to 12 weeks. And it is true that for those people, the symptoms are usually mild and self-limiting. Not for everybody. Some people already have severe symptoms coming off. But those papers influenced the guidelines. Drug companies coined the euphemism discontinuation symptoms, which if you try to define it, is of course exactly the same as withdrawal, because they wanted to distinguish their drugs from benzodiazepines, where the market had been affected badly by knowledge about withdrawal symptoms. And they distributed numerous papers with this description of brief and mild. Accordingly, the NICE guidelines recommended that stopping over 4 weeks was about right for most people. This guidance was based on a single study in which the drugs were stopped abruptly, and the committee thought that it produced too many withdrawal symptoms, so they came to the consensus that 4 weeks was enough. In other words, this was never based on any research. We know in common practice in the UK that this is the most common way that drugs are stopped. They are halved for 2 to 4 weeks, halved again, often by alternating day dosing, and then stopped. So people are stopped over about 4 to 8 weeks. A randomised controlled trial done in Holland a few years ago found that just 1 in 16 patients who had been on antidepressants for longer than 1 year were able to successfully stop with this manner. So it's a very unsuccessful technique for the majority of people who are stopping long-term antidepressants. You may or may not be aware that a lot of people leave healthcare and go to online forums to get advice on how to safely stop antidepressants. There are some large websites out there and Facebook groups where there are now almost 200,000 people. About half of them are from Europe. I don't know the exact percentage from France. We surveyed 1,300 of them and asked them why had they left their doctor's practice and gone to these online groups. And they said they found their doctor's advice unhelpful for a variety of reasons. They recommended reducing it too quickly. They were not familiar enough with withdrawal symptoms to advise me, or they told me that antidepressants do not cause withdrawal symptoms. And the most common period of tapering was 2 or 4 weeks by their clinicians. What did patients want? They wanted access to to ways of making more gradual reductions, things like liquids or compounded medications, to allow them to make smaller reductions that are possible with tablets by halving or quartering the dose. And they wanted health professionals that were able to provide a personalised, flexible reduction plan. And we'll talk more about what that looks like in a moment. So let me talk a little bit about the neurobiology of withdrawal, so it makes some more sense. This is a serotonin synapse. This is the presynaptic neuron, the postsynaptic neuron. Serotonin in the presynaptic neuron is released into the synapse where it turns red. These are the postsynaptic serotonin receptors that interact with synaptic serotonin and send signals through the postsynaptic neuron. And the blue columns are the serotonin transporter that are sucking serotonin out of the synapse back into the presynaptic neuron. When you introduce an antidepressant into the system, it blocks 3/4 of the serotonin transporter approximately, and that leads to less reuptake and increased levels of synaptic serotonin. Now, that means that these postsynaptic receptors are receiving much more signal than they normally would. And as a result of homeostasis, wanting to keep us in the middle, when it's hot outside, we sweat, when it's cold outside, we shiver. because of this excess of signal, there is downregulation of postsynaptic serotonin receptors. You can see that on neuroimaging after just a few weeks of exposure to antidepressants. You can see downregulation of serotonin 2 and serotonin 4 receptors and changes into 5-HT1A autoreceptors. Now when you come to stop the medication, months or years later, the antidepressant is metabolized from the system by the liver and kidneys in a few days or weeks. And so the serotonin transporter is free to do its usual mechanism, and serotonin levels return to normal in the synapse. But what doesn't return to normal very quickly is the changes in the serotonin receptors on the postsynaptic neuron. There are studies in humans that find that after stopping antidepressants, there are abnormalities to the serotonin system that last for up to 4 years after stopping, and similar findings in animals that there are changes in the hormonal system and serotonin system in the brains of animals for more than a year in human equivalent time. In other words, the brain doesn't just quickly snap back into how it was before the drugs were there. It takes a while to readapt. This explains why withdrawal symptoms can be so long-lasting after stopping a drug, because what often happens is that a patient goes into their doctor and complains of weeks or months of symptoms after stopping an antidepressant, and the doctor says, well, that can't be because of the antidepressant. The antidepressant has left your system. It takes a few days or weeks. It must be something else. But that relies on a misunderstanding of what causes withdrawal syndromes. I'll just illustrate it here. Withdrawal syndromes last for as long as it takes the receptors that were downregulated to go back to normal levels. And because that can take months and years, that's why the withdrawal syndrome can take months and years. Because while it's in this state, what you have is normal levels of serotonin, lower levels of postsynaptic neurons. This altogether leads to a hyposerotonergic type of syndrome. This is just one, this is obviously a simplified cartoon. There are other neurotransmitters affected in the same way, and there are also downstream effects. But you can see how these changes can have run-on effects. I'll give you one quick analogy to make sense of why people can have long-lasting withdrawal symptoms. When you go to a loud concert, your eardrums adapt to the level of sound. They become less sensitive to sound. When you walk out into the quiet street afterwards, people's voices sound muffled for a few minutes. It's actually a sound withdrawal syndrome. The reason why it happens is when you close the door on the concert, the sound goes back to normal in a second. The reason why it takes a few minutes is it takes a few minutes for your eardrums to relax to normal levels of sensitivity. In other words, the adaptations of the brain to the sound is what takes a while. The same is true for psychiatric medications. Although when you stop an antidepressant or a benzodiazepine, the effects of the drug on receptors go to normal in a few days or weeks. The adaptations made in the brain to the presence of the drugs can take months or years to resolve, and that's why withdrawal syndromes are thought to be able to last so much longer after stopping. But that causes huge confusion for diagnosis. Already said these things. So antidepressant withdrawal syndrome is a physiological collection of symptoms that occur on stopping or reducing the dose of an antidepressant. They can manifest in either psychological or physical symptoms because these drugs affect multiple systems. They don't just affect the central nervous system, they affect the peripheral nervous system, the hormonal system, and the gut. They occur because adaptations to the brain caused by the drugs take time to resolve. Withdrawal symptoms do not require addiction. This is a common misconception. Addiction, compulsion, craving, not relevant to antidepressants, and also not relevant to most people taking benzodiazepines, gabapentinoids or Z drugs. 98% of those people are taking medications as prescribed by their doctors. They're not misusing it, abusing it, or doing anything untoward. This adaptation to drugs in pharmacological texts is called physical dependence. Unfortunately, I don't know in French, but in English, physical dependence and addiction have become interchangeable in medical language, which causes a great degree of confusion. So, for example, I imagine that everybody in the audience, including me, is physically dependent on caffeine. None of you are misusing it, abusing it, injecting it, stealing from your neighbours to get more of it. But if you stopped it, you'd get a withdrawal syndrome. So it doesn't require addiction to get withdrawal. And that misconception causes much confusion for people. So antidepressants, like most psychotropic medications, cause adaptation in the brain, which is normally referred to as physical dependence, but don't cause addiction in most people, and antidepressants don't cause addiction in general. The greater the degree of adaptation, so higher doses, longer use, the greater the withdrawal effects. The flip side of withdrawal is tolerance. So you don't get withdrawal without tolerance. The more tolerant you are to a drug, the more withdrawal you get. In America, they colourfully use the term poop out to describe tolerance effects. And it's the reason why early side effects wear off over time, because of tolerance to the drugs. There are a very long list of withdrawal symptoms. The acronym FINISH is often used, but it doesn't describe all the different symptoms that can occur. Dizziness, insomnia, impaired concentration, fatigue, headache, tremor, tachycardia, nightmares. There are mood symptoms like depressed mood, irritability, anxiety, panic attacks. We know that these are not just a return of people's underlying condition, because they occur as commonly in people who are given antidepressants for reasons other than mental health problems. So, for example, in studies of people who are given antidepressants for pain or the menopause, or even in healthy volunteers, they find these symptoms on stopping antidepressants. There are some quite distinctive sensory symptoms, things like electric shock sensations called brain zaps, a little sensation that there's a little electric shock has gone through people's heads, or their brains have been switched off for a second, it's often described as. There are gut symptoms because there's a lot of serotonergic neurons in the gut, and there's an increase in suicide attempts in the 2 weeks after stopping an antidepressant that has been thought too soon for relapse to explain it, and has been thought as a direct withdrawal effect. And another aspect that I wanted to draw attention to, which is often overlooked, is akathisia. So akathisia is well recognised as a long-term effect of antipsychotic medication, but there are published case reports on withdrawal from antidepressants and benzodiazepines causing akathisia. These are the worst patients that I see in my clinic. They are often they're full of terror, they're agitated, they're often pacing. They've described it to me as feeling like their nervous system is on fire, and they have a high risk of suicide because they are constantly in this sort of state of terror. And when clinicians are not aware that this is a possible effect of coming off antidepressants, it's often misdiagnosed as agitated depression, mania, or psychosis. So how, you may have seen in the news in the last couple of weeks, a paper was released, I think it was reported in Le Figaro, how common severe and long-lasting withdrawal symptoms are. So there was a new meta-analysis released in the Lancet Psychiatry looking at withdrawal effects from antidepressants. It looked at 76 studies, and it concluded that 1 in 3 people have withdrawal effects when they stop antidepressants, 1 in 6 when they stop placebo. Subtracting that, they got 1 in 6 will have withdrawal symptoms, and they said that 3% of people will experience severe withdrawal symptoms. But there are some limitations to the meta-analysis, which means they almost certainly underestimated the risks. Most of the studies were conducted by drug companies. That's important because most of these studies were not set up to look for withdrawal symptoms. They were efficacy studies to get the drugs approved. And after an 8 to 12 week trial with the medication, they stopped the drug for 2 weeks, and they often relied on spontaneous report by patients to detect withdrawal symptoms. In other words, they didn't put a lot of focus on looking at withdrawal effects because that wasn't the main point of these studies. Some of the studies, in fact the largest ones, were chart reviews where doctors went through their clinic lists over the last few years and tried to work out what proportion of people met criteria for withdrawal effects, and they got very low numbers, like 5%, and they didn't say how they did it. Very likely to underestimate the risks. Only 6 out of 76 studies used a standard instrument like the DEST to detect withdrawal. They also did this subtraction where they subtracted placebo withdrawal from drug withdrawal. They treated them as like with like, but they found in their own data that people that stopped antidepressants were 6 times more likely to have severe withdrawal effects. In other words, if you asked a group of people, do you feel a bit dizzy or nauseous, probably a proportion would say yes. But when people stop antidepressants, they can be so dizzy they walk into walls or have car accidents, and so nauseous they vomit. So they're not probably comparing like with like when they do that subtraction. But perhaps most importantly, the duration of use of people in these studies was on average 25 weeks, about 6 months. We know, I don't know the data for France, I couldn't find it unfortunately, but in the US, more than half of people on antidepressants use them for more than 5 years. That's 25 million people. In the UK, more than half of people use them for more than 2 years. So looking at studies for people who have only been on them for 6 months is probably going to underestimate the effects for people in the long term. It's known that for most drugs, the longer you're on them, the more difficult and severe withdrawal effects are. This is a survey that looked at longer-term use that we published last year. This is duration of use of antidepressants before stopping. The top line is, did you experience any withdrawal effects at all? And the bottom line is, were these effects moderately severe or severe? And so when you look at 6 months of use, the same as was done in the study, we found almost identical results to them. About 1 in 3 people experienced withdrawal effects, and most of it was not severe or moderately severe. But by the time you're using the drugs for more than 3 years, 2/3 of people are reporting withdrawal effects, and half of them are saying it's severe. So there's a clear biological gradient, as you would expect, with longer-term use. And so this recent review has almost certainly underestimated how many people experience withdrawal effects and how severe they are, especially long-term users, which of course is where the major concerns lie. I just want to highlight quickly protracted antidepressant withdrawal syndrome. I've actually started getting emails from patients in France since I've started publishing on this work to talk about, to complain to me that their long-term withdrawal symptoms are not recognised by doctors in general. There are now several papers focusing on these issues, that people can have months or years of symptoms. They can be debilitating for some people. They involve a lot of the symptoms of acute withdrawal, psychological, neurological and somatic symptoms. People can be so unwell they are bedbound, lose jobs and relationships. There's very poor recognition by the medical community. It makes me think a bit of long COVID. People first of all said, how can a short-term virus cause long-term trouble for months or years after stopping? There was quicker recognition of long COVID because it was so widespread and because doctors were involved, were affected, which made people much more sympathetic. Now there are now thousands or tens of thousands of people who end up on peer support sites because these issues from coming off the medications are not recognised by the health system. And there are similar issues that have been recognised for many years, long-lasting protracted withdrawal from benzodiazepines, from gabapentinoids, and also from antipsychotics. A major issue reported by many of the patients that we surveyed, one of the reasons they were on these peer support websites, was that their withdrawal symptoms were misdiagnosed as relapse or return of an underlying condition. It was reported by most patients in these forums. It's easy to understand why that would occur. Withdrawal symptoms include anxiety, depressed mood, insomnia, irritability, panic attacks, suicidality. It would be easy for a clinician to confuse that when someone walks into your office and they say, stop my medication, I feel terrible. The instant next thought is, of course, these people must have relapsed, especially when guidelines have said for many years that withdrawal symptoms are mild and brief. Someone walks in with severe symptoms that are long-lasting, it doesn't match what the guidelines say. There are a few clues to distinguish withdrawal from relapse. In general, withdrawal has quicker onset, often in a few days, but more and more it's been recognised that these symptoms can be delayed in onset. The brain elimination time for antidepressants is actually longer than the plasma half-life. So there's a paper in molecular psychiatry showing that it can take several weeks for antidepressants to leave the central compartment, and therefore withdrawal effects can be delayed in onset, which I've seen several times in clinical practice. There are specific symptoms that help to distinguish withdrawal from relapse. So things like dizziness, electric shock sensations that are clearly not a part of anxiety or depression help to mark it out as a withdrawal syndrome. But in studies that we've done, the most common withdrawal symptoms are emotional symptoms. Anxiety, depressed mood, panic are the most common symptoms. One thing that's very useful is to know what were the symptoms the patient had when they went on medication. So, for example, if a patient was put on medication after the death of their mother and they were very lethargic, depressed, sleeping long hours, and now when they stop an antidepressant, they're anxious, they're having panic attacks, and they have insomnia, it's much more likely that they've developed common withdrawal symptoms than coincidentally developed a new onset panic disorder that just happened to coincide with the moment they stopped antidepressants. But often clinicians will make that diagnosis of a new onset panic disorder. So it's very useful to know what the symptoms were before and afterwards. Sometimes patients will make this clear by saying, I've never felt like this before, or these symptoms are much more severe than I've ever had before. And those are clues that what you're dealing with is withdrawal and not a relapse. More often useful in retrospect is if you get put back on medication soon after stopping with withdrawal symptoms, the symptoms improve quite quickly, whereas it can take longer if it's a relapse. Because of a lack of education about withdrawal symptoms, many people are misdiagnosed with a variety of different diagnoses: chronic fatigue syndrome, medically unexplained symptoms, neurological disorders, onset of a new psychiatric disorder, because all the symptoms I've listed overlap with the diagnostic categories of all of these different conditions. And so misdiagnosis is very common. In the UK, all of this research led to an update in the guidelines in the last couple of years. In 2019, the Royal College of Psychiatrists put out a position that patients should be informed of the potential for severe and long-lasting withdrawal symptoms. They actually went on national TV and did a series of news items to let the public know about this. NICE, the government department, charged with putting out medical guidelines, also updated its guidance to say withdrawal symptoms can last longer, in some cases weeks, occasionally several months, and it can be years, and can sometimes be severe. So if that's the problem, I want to talk a bit about the solution, how to minimise withdrawal symptoms from antidepressants when stopping them. So maybe I'll quickly say why is it worthwhile stopping antidepressants? There's a variety of different reasons. The medications may no longer be needed. Many people are put on a medication at the time of a major stressor, and this may have resolved. So often the context of divorce, job loss, physical health problems, death in a family. In these cases, and I'm often talking to general practitioners as well as psychiatrists, probably seeing slightly different groups of people, but in primary care, relapse of these conditions are unlikely. You're seeing people who don't have recurrent disorders. I'm sure that's a bit different for your patients. People may have developed alternative coping skills, and this is very true and known in the UK. Many people are using these medications for longer than guidelines recommend. So most guidelines recommend 6 to 12 months for anxiety or depression, and many people are on these for years and sometimes decades. People's quality of life can be improved by removal of side effects. So many side effects in long-term use are higher in incidence than they were reported in short-term studies. So more than 50% of people experience sexual side effects. We now know that a portion of people, after stopping medications, will continue to have sexual side effects, what's known as post-SSRI sexual dysfunction, now recognised by the EMA. More than half of people report emotional numbing, that is a constriction of both positive and negative emotions, which can be very useful for people in the short term potentially, but it also is the main reason people come to our clinic in London to come off medications. They feel it's impacted their quality of life, intimacy, their sense of who they are. Fatigue, impaired memory, and impaired concentration are all common, and those have all been shown to occur in healthy volunteers given antidepressants. So it's not just underlying conditions. Insomnia, and there's an increasing concern about worsened anxiety and depression in the long term, what's called tardive dysphoria. And weight gain, which wasn't seen in 6 to 12-week studies, is clearly seen in longer-term studies. There are no long-term randomized controlled trials that compare placebo and antidepressants. So all we have is observational data where people on antidepressants are compared to people not on antidepressants. And in these studies, some of which are in the British Medical Journal, they find that people on antidepressants have an increased rate of strokes, obesity, falls, cardiovascular disease, osteoporosis, cataracts, and premature mortality. And there's a debate about the degree to which that is explained by underlying conditions or the drugs themselves. For at least some of these conditions, the drug itself has been implicated. Patients may wish to stop. They may wish to pursue alternative strategies. Young women may wish to stop to become pregnant. There are pros and cons to being on and off medication, but the studies are fairly clear that there's an increased risk of teratogenicity in women on antidepressants from a low base rate, but increased by 2 to 3-fold. For older people, reducing pill burden or interactions may be a major motivation. And I'll add in one quick point here, which is the evidence for the long-term use of antidepressants has been challenged in the last few years based on confounding by withdrawal symptoms. I'll just quickly outline what that is. Again, this is talking about British guidelines, although I'm sure it's very similar in France. The recommendation to continue antidepressants in the long term for people at risk of relapse is based on discontinuation studies. I think sometimes people think that they're based on studies which have compared people on placebo to antidepressant for many years. but they're not. There are no studies that go for longer than 6 months that do that. So all these studies are based on stopping studies. And the studies look like the following. They take a group of people, patients who are remitted on antidepressants, that is, their depression has resolved. They are randomised to either stop or continue their antidepressants. They have relapse detected for the next 6 to 12 months, which is where 6 to 12 months comes from in the guidelines. And if you put together all these studies, as a famous meta-analysis did in the Lancet by John Geddes, you find that about 40% of people who stop antidepressants relapse, and about 18% do in those who continue on medication. And the difference between that is why guidelines recommend to continue on antidepressants. The issue with these studies is, number one, it's already a highly selected group of people who have remitted to medication, but more importantly, most antidepressants in these studies are stopped in 1 day, stopped abruptly, and the average period of time is 5 days. So these people are going to have high rates of withdrawal effects. Withdrawal effects include anxiety, sleep, insomnia, mood, all of which overlap with all of the diagnostic criteria in the Hamilton Depression Scale, the PHQ-9, whatever you're using. Withdrawal symptoms are not measured or excluded in any of these studies. They're mentioned sometimes in the discussion, but they're never excluding patients based on this, which means that some of the people in this group of relapses are going to be withdrawal symptoms misclassified, which means that the difference between these two groups is not going to be as big as it's sometimes said to be. And in fact, some researchers have looked at these studies to try to estimate what degree is due to withdrawal and have concluded that this may all be explained by withdrawal effects. In other words, what these studies are demonstrating is not that antidepressants prevent relapse, but that antidepressants prevent antidepressant withdrawal. So just to use it to make the point a little bit glibly, if you took a group of people who were smokers and you divided them into stopping smoking or continuing smoking, and you measured anxiety scores, you'd find the people that stopped and you ignored withdrawal, you'd find the people that stopped smoking would have higher anxiety relapse rate, and you would conclude that people need to continue smoking to prevent anxiety returning. In other words, ignoring withdrawal effects leads to very perverse interpretations of studies. And so the studies for many psychiatric drugs follow the same pattern. It's true for antipsychotics, benzodiazepines, and gabapentinoids all suffer from stopping the drugs quickly, ignoring withdrawal effects, and calling everything relapse, which means many of these studies on long-term use of these drugs are misleading and inflate the effects of the drugs. The Royal College of Psychiatrists published a guidance on stopping antidepressants now a few years ago, and it made several high-level recommendations. People who have been on antidepressants for more than a few weeks should taper off over months or years. They suggest going down to very small doses before stopping, less than 1 milligram for people that have difficulties. And they recommend going down in smaller and smaller size reductions, and that the rate should be adjusted to the individual's ability to tolerate the process. I'll explain where some of those maybe slightly strange-sounding recommendations come from. So we published an article in the Lancet Psychiatry a few years ago looking at the effect of antidepressants on the brain. This is an example of for citalopram on the x-axis, and this is effect on the serotonin transporter on the y-axis. And the key point from these neuroimaging studies is that the relationship is not a straight line. Doubling the dose doesn't double the effect. So 40 milligrams doesn't have double the effect of 20 milligrams. And in fact, a tiny dose, like 2 milligrams of citalopram, actually has about half the effect of 40 milligrams. It's quite surprising. The reason why this relationship comes about is because of the law of mass action, which basically says when there's not much drug in the system, all the receptors are unsaturated or open for business. So every milligram of drug has a very large effect. A little bit like the game of musical chairs. At the beginning of the game, it's very easy to find a chair. As there's more and more drug in the system, more and more of the receptors are saturated, and every extra milligram of drug has less and less effect, like at the end of the game of musical chairs. And so this shape is called a hyperbola. And this relationship is not just true for citalopram, it's true for all antidepressants. In fact, it's true for all psychiatric drugs, because it's a general law of pharmacology. And it's not just true for the serotonin transporter, it's true for all targets, because it's a general pharmacological law. This allows us to understand what happens when people stop antidepressants in the usual way recommended by doctors. The most common advice is to halve the dose, quarter it, and then stop. So you start at 20 milligrams, you say halve the tablet for a couple of weeks, then halve the tablet and take it every second day for a couple of weeks. And what that does in terms of effect, and it sounds kind of intuitive and it's easy to do with existing tablets, but if you look at the effect on the brain, the first reduction causes a change in effect. Some people find that quite difficult. Some people can tolerate that. The next one from 10 to 5 is bigger again. But going from 5 to 0 is like jumping off a cliff. If you imagine walking down this occupancy curve, it starts off as a easy country walk, becomes a steep hill, and then a steep cliff. And this is exactly what patients report. That the first few milligrams of the drug are the easiest to reduce and the last few milligrams are the hardest. And when clinicians aren't aware of this relationship, they conclude that people must need these last few milligrams, it must be psychological, or they just see relapse, people are getting anxious and depressed. What would make more pharmacological sense is not reducing the drugs by an even amount of effect on dose, but by an even amount of effect on the brain. So in this diagram, I've drawn 4 horizontal lines separated by 20 percentage points of receptor occupancy. And what that requires is going down by smaller and smaller amounts, because it's following this curve, and going down to very small final doses before stopping. So going from 0.8 milligrams to 0 will cause the same size of change in effect on the brain as going down from 20 to 5. So you need to go down to very small final doses so that final jump down is not bigger than the reductions that have been previously tolerated. And because this curve is called a hyperbola, this has been referred to as hyperbolic tapering. And this is now the sort of approach to tapering that the government recommends in the UK and the Royal College as well. Just to make it slightly simpler, sometimes people will abbreviate this by talking about proportional reductions. So, for example, if you reduce by 50% of the dose, say every month, you'd go down from 20 to 10 to 5, 2.5, 1 1/4, 0.6. That gives you roughly even changes of effect on the brain, and it's a bit simpler to explain in a second. Some people will find even these reductions to be too large, and you can insert intermediate steps. So people can reduce by 25% of their dose per month, or as slowly as 10% of their dose per month, so that reductions get smaller and smaller. The Royal College guidance recommends that the rate of reduction should be individualised to the person, because it's quite hard to guess who's going to have trouble. I'll show you later on. We've put together a tool to estimate risk, but ultimately it's the experience of the patient that should guide what rate they go at, because the research is under-established so far. If withdrawal symptoms become too severe, the college recommends the reduction should be halted or the dose increased until symptoms resolve, and then the reduction should proceed at a slower pace. And they reiterate many patients can only reduce their dose at 10% of the most recent dose per month, which means reductions get smaller and smaller. They give some examples of regimens in their guidance. Here's a guide for citalopram. I think this would be appropriate for someone who's been on the drug for a year or two, not for very long-term users. Halving the dose every fortnight or month, going down to these very small doses where they start to recommend using liquid versions of the drug, and that would take several months. And an even slower reduction for someone taking a drug like paroxetine or venlafaxine or duloxetine or mirtazapine, which can be even harder to stop, which involves going down at 10% of the dose per month. So when you're at 40 milligrams, you start by reducing by 4 milligrams. By the end, you're going down at 2 milligrams per month. And in fact, there's actually 30 further steps here. This certainly plays out in practice in my clinic. I see lots of people who take 2, 3, or more years to come off paroxetine because the withdrawal effects can be so brutal. So the question always comes up: how do you make up these small doses? This diagram in the top right is a bit helpful as a cartoon. The smallest available tablet for most antidepressants, so taking citalopram, in England it's 10 milligrams, I think in France it's 20 milligrams. The smallest available dose still produces a very high effect on the brain. Even half of that dose, or a quarter of the dose, also produces a high effect. So it's often too high for people to safely stop at. I'm told that there are some liquid versions of antidepressants available in France. It sounds like it's not very widespread. In England it's much more widespread. About 90% of drugs are available in liquid form because they were asked for by clinicians. You can go to compounding pharmacies to make up smaller doses. If there's a demand for it, people will step into the fray. Other ways that people try to reduce slowly is by skipping doses, and that can be problematic. So most antidepressants have a half-life of about 24 hours, and so if you dosing every day, you go down to half and then back up. If you dose every second day, 2 half-lives, you go down to a half and then a quarter and back up again. Many people can experience quite severe withdrawal effects from that kind of up and down. So it's better. The only exception to that is fluoxetine for antidepressants, which does have a long half-life, and dosing every second or third day is reasonable. But for most antidepressants, it's better to give the same small dose every day rather than skipping doses. And there's another idea out there, which comes from the manufacturer, that fluoxetine is self-tapering. Now, this arises because the manufacturer of Prozac did a study in the 1990s where they stopped a variety of people on antidepressants for 1 week, and they showed that sertraline had very high withdrawal effects, paroxetine even higher, citalopram as well, but fluoxetine didn't have any withdrawal effects, and they said, our drug has no withdrawal effects, it's self-tapering. But of course, it's very misleading because the half-life of fluoxetine is a week or two because it's got an active metabolite, norfluoxetine. So stopping the drug for a week doesn't give enough time for withdrawal effects to arise. So fluoxetine is notorious for having delayed onset withdrawal effects because a few half-lives can take a couple of months. So it's not true. So it is true that fluoxetine has a little bit of a self-tapering aspect to it because it's slower, but it's not slow enough to just stop it and let people come off that way. So about half of people who stop fluoxetine will have withdrawal effects from studies. So it's still worthwhile tapering fluoxetine carefully. And switching to fluoxetine, again, comes from the manufacturer. They call it the Prozac bridge, and they base it on that study I talked about. I've seen it work. I've also seen it not end up well because I think there are bigger differences between antidepressants in the SSRI class than there are between benzodiazepines. And sometimes switching from sertraline to fluoxetine doesn't work out well. So in general, in our clinic, we taper people from the original drug they're on rather than doing a switch to fluoxetine. I'll just quickly I've talked a lot about theory. Let me talk about quickly evidence for a few minutes and have some time for questions. So in a meta-regression of 13 antidepressant discontinuation studies, there was a very high degree of a correlation between rate of stopping and risk of relapse. So the slower people stopped antidepressants in studies, the lower the risk of relapse. In fact, in 3 trials that tapered over about 6 months, there was no difference in relapse rates between maintenance on antidepressants or stopping. In another study of 900 patients, where most of them had been unable to stop antidepressants in the usual way with their clinicians, they were able to stop, 3/4 of them were able to stop with a hyperbolic taper over several months. In this book, we try to make it easy for people to implement clinically. We go through every single drug available in France, antidepressants, Z drugs, benzodiazepines, gabapentinoids, how to distinguish withdrawal symptoms from relapse, how to taper each drug according to either fast, moderate, or slow based on people's risk factors, how to adjust it based on trouble that comes up, troubleshooting, and also which formulations are available for every drug and how to make up reductions using either tablets or liquids with some options that are off-label. I'll go through this bit quickly. This is an example of risk stratifying based on people's duration of use, which antidepressant they're on, what dosage, and their past experience to work out what risk category they could fit into, because of course, if someone's been on a drug for a few months, there's no need to taper them off over years. But also, if someone's been on venlafaxine for 20 years, you want to be very careful. So it's trying to start to distinguish who's going to have trouble and who's not. Here are some examples. Textbook, here's the now familiar one for citalopram, telling you which doses, when to use tablets, when to use a liquid version, how to make that up. People that have trouble, there's a moderate taper, a bit slower with more steps, guiding people how to come off safely. And I'll just talk about other psychiatric drugs for a minute. So everything that I've said for antidepressants also applies to other psychiatric drugs. So the NICE guidelines in the UK say exactly what I've just said about antidepressants for other drugs. So for opioids, for benzodiazepines, for Z drugs, suggest a slow, stepwise rate of reduction proportionate to the existing dose. So that the use of that word proportionate, where you're getting smaller and smaller reductions as you go down to lower doses, unless there's a reason for rapid withdrawal. And that's because these same relationships I've shown you for antidepressants also are relevant to other drugs. Here's diazepam's effect on the GABA receptors in neuroimaging. Again, the same curve, just to make it really blatant. Going from 100 milligrams of Valium to 75 milligrams causes a smaller change in effect on GABA occupancy than going from 1 milligram to no milligrams. In other words, that final milligram is a lot harder than the original reductions. And here's some examples of reducing diazepam in the Maudsley Guidelines, quicker and slower versions. Same is true for pregabalin and also for gabapentin, the same curve for the same reasons. And antipsychotics, exactly the same things pertain. So there's a neuroimaging for haloperidol and for risperidone, again showing the same pattern of relationship. There's been more research for antipsychotics, and so you can even see that the clinical effects of antipsychotics also match this hyperbola. So this isn't just a neuroimaging finding divorced from clinical reality. This is a meta-analysis done by Stefan Lucht, looking at risperidone dose equivalent and effect on psychotic scores using the PANSS or BPRS. And again, you see the same relationship, that bigger effects happen at smaller doses. And so the same way of reducing makes sense, this hyperbolic approach. Taking the example of haloperidol, the reduction from 0.25 milligrams, which is a quarter of the smallest tablet available in France, will actually cause a larger change in effect on the brain than going from 10 milligrams to 2 milligrams. So these final small doses have very large effects. In fact, you can see here that going down from 0.08 milligrams to 0, a tiny little dose that you'll need a liquid version of the drug for, has about the same effect as going from 30 to 4. So just to emphasize how small these final reductions need to be. And you can see that for common antipsychotics, this is from a paper we published in 2021 in Schizophrenia Bulletin, that the final dose for 10 evenly spaced steps are very tiny doses, all much smaller than widely available tablets, in order to stop people falling off that cliff at the end of these curves. I'll spend 1 minute. So to talk about antidepressants, but a lot of what I'm saying is true for other psychiatric drugs. Feeling anxious or depressed when reducing or stopping antidepressants is not necessarily a sign of relapse. These symptoms are common in withdrawal, and they can be very familiar. It's another thing. If everyone here drank too much caffeine, everyone would become anxious, but you become anxious in a way typical of yourselves because it's your minds that the chemical effects are being filtered through, and the same can be true for people coming off psychiatric drugs. They can have very familiar emotions because it's their mind experiencing the withdrawal effects. Withdrawal effects are usually mild and brief after several weeks of use, but can be severe, prolonged, and debilitating after longer-term use. Tapering antidepressants over much longer periods, months or sometimes years than usual practice, weeks, is more likely to be successful. There's more and more studies now showing that. Making reductions by smaller and smaller amounts as total dose gets lower, called proportionate or hyperbolic tapering, is also is a more sensible approach. Some patients will need to go down to very small doses before stopping, e.g. a fraction of a milligram for many antidepressants. And a good rule of thumb for people on long-term antidepressants or other psychiatric drugs is reducing at 10% of their most recent dose every month, so that the reductions get smaller and smaller. In order to make these small reductions, patients will often need access to drugs other than widely available tablets, which I know is a headache. It provides a major barrier. In England, we are working with the National Health System to make liquids more easily available to GPs and psychiatrists to be able to do this with patients. The rate of tapering should be modified based on the ability of the patient to tolerate reductions. If you forget everything I've said, if you go at a rate, making small reductions at the rate a patient can tolerate, then things will go generally well. With the exception of fluoxetine, most antidepressants and other drugs that have a half-life of about 24 hours shouldn't be dosed every other day or less frequently because they can cause withdrawal effects. It's better to take the same dose every day. There's now guidance from the Royal College of Psychiatrists I showed you, NICE, and the textbook I showed you, the Maudsley Deprescribing Guidelines, that outline how to stop these drugs safely. And everything I've said for antidepressants is essentially true for benzodiazepines, Z drugs, gabapentinoids, antipsychotics, and mood stabilizers because they all obey that same pharmacological law. Happy to take any questions.